Welcome to the deep dive. Today, we're really getting into the heart of things, literally cardiovascular health and nursing care.
That's right. We're drawing from the Saunders NCLEX-PN Examination review to give you the essentials.
Exactly. Our mission really is to equip you with that core knowledge, assessments, procedures, safety, interventions, everything you need for cardiovascular care.
And we'll be focusing on two really key concepts throughout: health promotion and perfusion, keeping people healthy and making sure that blood gets where it needs to go.
Perfect. And to get you thinking right away, here's a scenario. You have a hospitalized patient, known abdominal aortic aneurysm. Suddenly, they report severe back pain and they're short of breath. What's the first thing you, as the nurse, should do?
Good one. Keep that in the back of your mind. We'll circle back to it at the end.
Okay, let's kick things off with the fundamentals, the anatomy and physiology, the heart itself.
Right. So the heart, it sits a bit to the left in your chest, in the mediastinum, and it has three main layers.
So there's, okay.
Yeah, the epicardium is the outermost protective layer. Then you have the myocardium, that's the big one, the muscle that does all the pumping.
The workhorse.
Exactly. And inside, lining the chambers and valves, is the endocardium, nice and smooth.
And isn't there a sac around the whole thing?
Yep, the pericardial sac. Think of it like a protective bag. It has two layers itself, a tough outer one, the parietal, and a thin inner one, the visceral, that sticks right to the heart surface.
And there's fluid in between.
Just a little bit, maybe 5 to 20 millimella. It's pericardial fluid, acting like a lubricant and cushion. Protects against bumps, infection, that sort of thing.
Got it. Now, inside the chambers, 4 of them.
4 chambers. Let's start on the right atrium. It's like the receiving dock for all the deoxygenated blood coming back for your body through those big veins, the vena cava.
Our pamphlet comes in there.
Then it goes down into the right ventricle. And the right ventricle's job is to pump that blood out to the lungs through the pulmonary artery to pick up oxygen.
So right side sends blood to the lungs, then the left side.
The left side gets the oxygenated blood back from the lungs via the pulmonary veins.
Yeah.
This fresh blood enters the left atrium.
And then
Down into the left ventricle. And this one, the left ventricle, it's the powerhouse. Thickest walls, strongest pump. It has to push that oxygenated blood out through the aorta to the entire rest of the body.
that's a huge job. Seems like you'd need good control over that flow.
Valves, right?
Valves are critical. They're like one-way doors, keeping blood moving forward. You've got 2 main types. The atrioventricular valves, or AV valves, sit between the atria and ventricles.
Okay.
On the right, that's the tricuspid valve. On the left, it's the mitral valve, sometimes called the bicuspid. They snap shut when the ventricles squeeze, so blood doesn't go backwards into the atria.
Makes sense. And the other set.
Those are the semilunar valves. They're at the exit of each ventricle. The pulmonic valve is between the right ventricle and the pulmonary artery.
Going to the lungs.
Right. And the aortic valve is between the left ventricle and the aorta.
Going to the body. Exactly. These close when the ventricles relax, preventing blood from flowing back into the ventricles from the arteries.
Okay, so mechanical doors. But what tells the heart when to pump? The electrical system.
Precisely. It all starts with the sinoatrial node, the SA node. It's the heart's natural pacemaker.
Where's that located?
It's up in the right atrium, right near where the superior vena cava enters. It spontaneously generates electrical impulses, usually 60 to 100 times a minute. That sets the basic rhythm.
And the nervous system can adjust that rate.
Oh yeah, the autonomic nervous system fine-tunes it constantly based on body needs.
What if the SA node, has an off day? Is there a backup?
There is. The atrioventricular node, or AV node. It's located lower down in the wall between the atria. It picks up the signal from the SA node and relays it onwards. But if the SA node fails, the AV node can take over as a backup pacemaker.
But it's slower.
Yes, its intrinsic rate is slower, usually around 40 to 60 beats per minute.
Okay, so SA node, then AV node. Where does the signal go next to make the ventricles contract?
From the AV node, the impulse travels down the bundle of His, which runs through the wall, separating the ventricles.
The septum.
Right, the interventricular septum. This bundle then splits into right and left bundle branches, carrying the signal down towards the bottom of the ventricles.
And finally,
Finally, these branches connect with the Purkinje fibers, a whole network spread throughout the ventricular muscle walls. They deliver the impulse rapidly, causing both ventricles to contract in a coordinated way, pushing the blood out.
wow. And the Purkinje fibers can also be a backup.
They can, yes. If both the SA and AV nodes fail, the Purkinje fibers can initiate a beat, but it's very slow, maybe 20 to 40 beats per minute. really a last resort.
Incredible system. Now, the heart muscle itself needs fuel. That's the coronary artery's job, right?
Absolutely critical. These arteries branch off the aorta right at the beginning and wrap around the heart. The right coronary artery generally supplies the right side of the heart, the bottom part of the left ventricle, and importantly, often the SA and AV nodes.
Okay, and the left.
The left main coronary artery usually splits quickly into two major branches. The left anterior descending, the LAD.
The widowmaker.
Often called that, yes, because a blockage there can be so critical. It supplies the front and bottom of the left ventricle and the front part of the septum. The other branch is the circumflex artery, which supplies the left atrium and the side and back of the left ventricle.
So blockages anywhere in these are bad news, leads to heart attacks.
Exactly, myocardial infarction. That's why understanding which artery feeds which part of the heart is so important.
Now, when we listen to the heart, those lub-dub sounds, what are we actually hearing?
Good question. The first sound, S1, the lub, is the sound of those AV valves, tricuspid and mitral, closing when the ventricles start to contract. It's loudest usually at the apex, the bottom tip of the heart.
Okay, and the dub.
That's S2, the second heart sound. It's the sound of the semilunar valves, the aortic and pulmonic, closing when the ventricles relax. You hear that best at the base, the top part of the heart.
Are there other sounds you might hear?
Sometimes, yes. An S3 sound can sometimes be heard shortly after S2. It might indicate decreased ventricular compliance, like in heart failure, though it can be normal in kids or young adults. An S4 sound occurs just before S1 and is caused by the atria contracting forcefully against a stiff ventricle. S4 is almost always abnormal.
Interesting. And heart rate itself, faster isn't always better, is it?
Definitely not. If the heart beats too fast, there isn't enough time for the ventricles to fill completely between beats. So even though the rate is high, the amount of blood pumped out with each beat, the stroke volume goes down, and overall cardiac output can decrease.
So normal is 60 to 100, over 100 is tachycardia, under 60 is bradycardia.
Correct.
And the nervous system plays a big role in controlling this rate and the force of contraction.
Huge role. The autonomic nervous system has two branches. The sympathetic system, think fight or flight, releases norepinephrine. This ramps things up, increases heart rate, makes the heart beat stronger, and constricts blood vessels, usually triggered if blood pressure drops.
And the opposite.
The parasympathetic system rests and digests, releases acetylcholine. It slows the heart rate and decreases contractility. This kicks in more when blood pressure is high.
Okay, so blood pressure regulation is key. How does the body monitor and control BP?
It has sensors called baroreceptors, mainly in the arch of the aorta and the carotid sinuses in your neck. They detect stretching caused by blood pressure.
So if pressure goes up,
They get stimulated, send signals to the brain, which then increases parasympathetic activity and decreases sympathetic activity to slow the heart and widen vessels, bringing BP down.
and if BP drops,
Less stimulation of the baroreceptors triggers the opposite, more sympathetic activity to increase heart rate and constrict vessels, raising BP.
are there other sensors involved, like for blood volume?
Yes, stretch receptors, primarily in the large veins returning to the heart and the right atrium. They respond to changes in blood volume. Low volume triggers a sympathetic response to conserve fluid and raise pressure. High volume tends to do the opposite.
And hormones are involved too, right? Like ADH.
Absolutely. Antidiuretic hormone, ADH, is released from the pituitary gland. It tells your kidneys to retain water. So if blood volume is low or blood is too concentrated, ADH levels go up, you hold on to water, increasing volume and pressure. If volume is high, ADH drops, you pee more, volume and pressure decrease.
And the renin system, that sounds complicated.
It is, but it's crucial. When the kidneys sense low blood pressure or low sodium, they release renin. Renin starts a cascade. It converts angiotensinogen from the liver into angiotensin I. Then an enzyme in the lungs, ACE, converts angiotensin I into angiotensin II.
And angiotensin II is the powerful one.
Very powerful. It's a potent vasoconstrictor, directly raising BP. Plus, it stimulates the adrenal glands to release aldosterone.
Aldosterone, that makes you retain sodium.
Exactly. Sodium retention leads to water retention,
Sure.
which further increases blood volume and blood pressure. It's a major pathway the body uses to regulate BP long term.
Wow, it's such a complex balancing act. Okay, let's talk about the vessels themselves, the vascular system, the pipes.
Right. Arteries carry blood away from the heart. They're generally carrying oxygenated blood, except for the pulmonary artery. They have strong, elastic walls to handle the pressure. Then they get smaller. Yeah, they branch into smaller arterioles, which are key in controlling blood flow into specific tissues. They can constrict or dilate to regulate resistance.
And then the capillaries.
The capillaries are the tiny thin-walled vessels where the real action happens, exchange of oxygen, CO2, nutrients, waste products between the blood and the tissues.
After the capillaries.
Blood flows into small venules, which then merge into larger veins. Veins carry blood back towards the heart, usually deoxygenated blood, except for the pulmonary veins.
And veins have lower pressure, right? How does blood get back up from the legs?
Lower pressure, yes. Veins have thinner walls and rely on valves inside them, little one-way flaps to prevent backflow, especially in the limbs. Muscle contractions around the veins also help squeeze the blood upwards.
And the lymphatic system, how does that fit in?
It's like a parallel drainage system. It collects excess fluid, proteins, and other stuff from the tissues that leaks out of capillaries and eventually returns it back into the bloodstream near the heart. It's also crucial for the immune system.
Okay, that's a fantastic foundation in A&P. Now, how do we figure out if something's wrong? Let's talk diagnostics. Cardiac markers are usually first up, right?
Definitely. When heart muscle gets damaged, like in a heart attack, it releases certain proteins into the blood. Troponin is the big one, specifically troponin I and troponin T. They're very specific to heart muscle.
How soon do they show up?
They start to rise within about 3 hours of damage and can stay elevated for a week or even longer, maybe 7 to 10 days. Even small elevations are significant.
What else? CKMB.
CKMB is an isoenzyme of creatine kinase, mostly found in the heart. It also rises after damage, usually within 4 to 6 hours, peaks around 18 to 24 hours, and then comes back down over a couple of days.
And myoglobin.
Myoglobin is released very early, within 2 hours. But it's not specific to the heart skeletal muscle damage, releases it too. And it clears pretty quickly, usually within 7 hours. So it's less useful on its own.
So troponin is really the gold standard for detecting heart muscle injury. What about more routine blood tests?
Oh yeah, a CBC, complete blood count, gives us lots of clues. Low red blood cells could suggest conditions like rheumatic heart disease or endocarditis. High red cells might mean the body's compensating for poor oxygenation.
WBCs?
White blood cells often go up with infections or inflammation in the heart, like pericarditis or myocarditis, and also typically increase after an MI. Hematocrit can tell us about hydration status.
And clotting factors.
Important to monitor, especially after an MI, because the risk of forming clots like DVT or pulmonary embolism goes up.
Cholesterol is always a hot topic.
Absolutely. Serum lipid panels checking total cholesterol, LDL, the bad kind, HDL, the good kind, and triglycerides are essential for assessing coronary artery disease risk. We also sometimes look at LPA and homocysteine levels, as elevated levels are linked to higher risk.
What about inflammation markers, like HSCRP?
High-sensitivity C-reactive protein, yes. It measures general inflammation, and we know inflammation plays a big role in atherosclerosis. Higher levels suggest higher cardiovascular risk. Microalbuminuria, tiny amounts of protein in the urine, can also be an early sign of blood vessel dysfunction.
Electrolytes seem crucial given the heart's electrical nature.
Extremely. Potassium is a major one. Low potassium, hypokalemia, can cause dangerous dysrhythmias, especially if someone's on digoxin. High potassium hyperkalemia is even more dangerous, can lead to slow rhythms, even asystole.
Calcium and magnesium too?
Yep. Calcium imbalances affect contractility and rhythm. Magnesium is also vital. Low levels can trigger serious ventricular arrhythmias like VT or VFib. Sodium levels affect fluid balance and contractility too.
What about kidney function tests like BUN?
Blood urea nitrogen, BUN, can become elevated if heart problems are affecting blood flow to the kidneys. Blood glucose often spikes during acute stress, like an MI, even in people without diabetes.
And BNP, that's specific for heart failure.
Beta natriuretic peptide. Yes, the heart releases it when it's stretched and under pressure, like in heart failure. The higher the BNP level, generally the more severe the heart failure. A level under 100 pg/ml is usually considered normal.
Okay, lots of info from blood tests.
Okay.
What about imaging? Chest x-ray.
Standard chest x-ray gives a good basic look at the heart's size, shape, and position, and can show things like fluid in the lungs.
And the ECG, electrocardiogram.
Fundamental tool, records the heart's electrical activity. Essential for diagnosing dysrhythmias, ischemia, infarction, hypertrophy, also helps monitor medication effects.
But sometimes a snapshot isn't enough. That's where Holter monitoring comes in.
Exactly. If we suspect rhythm problems that aren't happening constantly, a Holter monitor records the ECG continuously for 24 hours or longer while the person goes about their normal activities. Helps catch those intermittent issues.
Echocardiogram, the ultrasound of the heart.
Right. Uses sound waves to create images. Shows us the heart chambers, wall motion, valve function, estimates ejection fraction, how well the left ventricle is pumping. Can be done non-invasively over the chest Or invasively with a T, transesophageal echo, where the probe goes down the throat for clearer pictures.
And stress tests, making the heart work harder.
Exercise electrocardiography, or stress testing. We monitor the ECG and vital signs while you exercise, usually on a treadmill, to see if activity provokes signs of ischemia, like ST depression or chest pain.
What if someone can't exercise?
We can do pharmacological stress tests using medications like dipyridamole or dobutamine that mimic the effects of exercise on the heart's blood flow and workload.
What about nuclear imaging? MNPI.
Myocardial nuclear perfusion imaging. It uses a small amount of radioactive tracer injected into the bloodstream. A special camera tracks how the tracer is taken up by the heart muscle, showing areas of good or poor blood flow, both at rest and after stress.
MRI can look at the heart too.
Cardiac MRI gives really detailed images of the heart's structure, function, blood flow, and can even characterize tissue, like identifying scar tissue from a previous MI without using radiation.
And for really digging into the electrical system, like electrophysiology studies.
EP studies, yes. These are invasive. Catheters with electrodes are threaded into the heart to map the electrical pathways directly and even try to induce arrhythmias to pinpoint their origin and guide treatment like ablation.
EBCT scans for calcium scoring.
Electronic beam CT can detect and quantify calcium deposits in the coronary arteries. A higher calcium score generally means more plaque buildup and higher risk. A score over 400 often triggers more aggressive treatment.
And the most invasive, cardiac catheterization.
Cardiac cath is often considered the gold standard for visualizing the coronary arteries. A thin catheter is guided into the heart, usually from the groin or arm. We can measure pressures inside the heart chambers and inject contrast dye to take X-ray videos, angiograms of the coronary arteries to see blockages.
Can look at valves and function too?
Yes, assess valve function, measure cardiac output, look for structural defects. IVUS, intravascular ultrasound, uses a tiny ultrasound probe on the catheter tip to get images from inside the artery wall, showing plaque details.
Okay, a whole arsenal of tests. Now let's talk treatments. What about opening up blocked arteries without major surgery? PTCA.
Percutaneous transluminal coronary angioplasty, that's the balloon one. A catheter with a balloon tip is threaded to the blockage, the balloon is inflated, squashing the plaque against the artery wall and widening the opening.
Does it stay open?
There's a risk of restenosis, the artery narrowing again, and complications like dissection, rupture, or clots can happen. But it's often the first line for acute MI or stable angina. Laser angioplasty uses a laser instead of a balloon to vaporize plaque, usually for smaller blockages.
Stents often go along with angioplasty, right?
Very often. Coronary artery stents are tiny mesh tubes mounted on the balloon catheter. After the balloon opens the artery, the stent is expanded and left behind as a scaffold to keep the artery propped open. Reduces restenosis rates significantly.
Big concern with stents.
Acute thrombosis, a clot forming inside the stent. That's why antiplatelet therapy, like aspirin and clopidogrel, is absolutely crucial, usually for at least several months, sometimes longer. Bleeding is another risk to monitor.
What's atherectomy?
Atherectomy actually removes the plaque. Different devices use either a cutting chamber or rotating blade to shave or grind away the plaque, which is then usually suctioned out, used for certain types of blockages. Risks include perforation or emboli.
Transmyocardial revascularization? TMR? That sounds different.
It is. It's usually for patients with severe angina who aren't candidates for PTCA or bypass. A laser creates tiny channels directly through the heart muscle into the left ventricle. The idea is to allow blood from the ventricle to perfuse the ischemic muscle directly, though the exact mechanism is debated.
What about fixing arteries in the legs? Peripheral arterial revascularization.
Similar concepts, but applied to leg arteries. The goal is to restore blood flow to a limb affected by PBAD. Inflow procedures bypass blockages high up, like in the aorta or iliac arteries. Outflow procedures deal with blockages lower down in the femoral, popliteal, or tibial arteries. Can be done via bypass surgery or endovascularly with balloons and stents.
And the big one, CABG, coronary artery bypass grafting.
The classic open heart surgery. Surgeons take a healthy blood vessel from somewhere else in the patient's body, often the saphenous vein from the leg or the internal mammary artery from the chest wall, and use it to bypass the blocked coronary artery segment. Reroutes blood flow around the blockage.
Is it always open heart?
Not always. Mid-cab, minimally invasive direct coronary artery bypass, can sometimes be done through smaller incisions, often for bypassing the LAD artery using the internal mammary artery, sometimes without needing the heart-lung machine.
And for end-stage heart failure, heart transplant.
The ultimate option when other treatments fail. Requires a suitable donor heart, complex surgery, and lifelong immunosuppression to prevent rejection.
How do recipients fare?
Survival rates have improved greatly. The transplanted heart is denervated, so patients won't feel typical angina, and the resting heart rate is often faster, around 100, with a slower response to exercise. Rejection is a constant concern. Signs include low BP, dysrhythmias, weakness.
Okay, let's shift gears to electrical problems, dysrhythmias. What's considered normal?
Normal sinus rhythm originates in the SA node, regular rhythm, rate between 60 and 100 beats per minute, everything conducting normally.
What if it's too slow?
Sinus bradycardia still originates in the SA node, regular, but rate is below 60. Might be okay in athletes, but if it causes symptoms like dizziness or fainting, it needs treatment. Maybe oxygen, atropine medication, or even a pacemaker.
And too fast.
Sinus tachycardia, regular rhythm from the SA node, but rate is over 100, up to maybe 180, usually caused by something else, fever, stress, dehydration, certain drugs. Treatment involves addressing the underlying cause.
What about atrial fibrillation, AFib? That sounds serious.
It can be. The atria are firing chaotically, super fast, like 350 to 600 times a minute, but disorganized. So the atria just quiver instead of contracting effectively.
Yeah.
The ventricles usually respond irregularly and often rapidly. You don't see clear P waves on the ECG.
Big risk with AFib.
Blood clots forming in the quivering atria, which can travel to the brain and cause a stroke. So treatment usually involves controlling the ventricular rate, anticoagulation to prevent clots, and sometimes trying to convert back to sinus rhythm with meds or cardioversion.
What are PVCs? Premature ventricular contractions.
Those are extra early beats originating from somewhere in the ventricles. They look wide and bizarre on the ECG because the impulse doesn't follow the normal pathways. They can feel like skipped beats or palpitations.
Are they dangerous?
Occasional PVCs are common and often benign. But frequent PVCs or certain patterns like couplets, 2 in a row, multifocal coming from different spots, or the R on T phenomena, falling on the T wave of the previous beat, can be more concerning and might indicate increased risk, especially after an MI. We also describe patterns like bigeminy, every other beat is a PVC, trigeminy, every third beat, etc.
Ventricular tachycardia, VT.
That's a run of 3 or more consecutive PVCs. The ventricles are firing rapidly, usually 140 to 250 beats per minute or more. It can be life-threatening because it might not generate enough cardiac output, and it can degenerate into ventricular fibrillation.
How is VT treated?
Depends if the patient has a pulse and is stable. If stable, oxygen and antidysrhythmic meds. If unstable, low BP, chest pain, altered consciousness, synchronized cardioversion might be needed urgently. Cough CPR can sometimes help briefly. If pulseless VT, it's treated like VFib, immediate defibrillation and CPR.
And ventricular fibrillation, VFib.
That's complete chaos. The ventricles are just quivering ineffectively. No coordinated contraction, no cardiac output. It's cardiac arrest. The ECG looks like messy squiggles, requires immediate CPR and defibrillation, the definitive treatment.
What about PSVT, paroxysmal supraventricular tachycardia?
PSVT is a sudden burst of a very fast, regular rhythm originating above the ventricles, often involving the AV node. Rates are typically 150-250 BPM. It starts and stops abruptly, often triggered by things like caffeine, stress, fatigue, can sometimes be stopped with vagal maneuvers.
And PEA, pulseless electrical activity.
This is tricky. The ECG shows some organized electrical rhythm, not VT or VF, but the patient has no pulse. The heart's electrical system is working, but the mechanical pumping isn't happening. You treat it with CPR and try to find and fix the underlying cause, like hypovolemia, hypoxia, acidosis, etc. Epinephrine is used.
So CPR is fundamental for pulseless situations. Remind us of the basics for adults.
Based on 2015 AHA guidelines, check responsiveness and breathing, call for help, activate emergency response. Check for a pulse, carotid, for no more than 10 seconds. If no pulse, start chest compressions immediately hard, at least 2 inches deep, and fast, 100-120 per minute in the center of the chest. Allow full chest recoil between compressions. Minimize interruptions. Give 30 compressions, then 2 rescue breaths, if trained and willing. Continue until help arrives and AED is ready or the person recovers.
Okay, let's talk more about managing these dysrhythmias, vagal maneuvers.
These try to stimulate the vagus nerve, which can slow conduction through the AV node and potentially terminate some supraventricular tachycardias like PSVT.
Like carotid sinus massage.
Yes, but only done by a trained provider. It involves gently massaging the carotid artery in the neck. Risks involved, so requires monitoring and resuscitation equipment ready. Valsalva maneuver bearing down as if having a bowel movement or inducing a gag reflex can also work sometimes. Need to monitor the patient closely.
When those don't work, or for more serious rhythms, cardioversion.
Cardioversion delivers a synchronized electrical shock. It's time to hit the R wave of the QRS complex, avoiding the vulnerable T wave period, which could induce VFib, used for unstable tachycardias like AFib, A-flutter, or VT with a pulse, usually uses louder energy than defibrillation.
Preparation needed.
Yes, sedation is usually given as it can be uncomfortable. If it's elective for AFib, the patient might need anticoagulation beforehand, and digoxin is often held for 48 hours prior.
And defibrillation.
That's the emergency, unsynchronized shock for life-threatening pulseless rhythms, VFib and pulseless VT. The goal is to depolarize all the heart cells at once, hoping the SA node will then take over with the normal rhythm. Higher energy is used 120-200 joules for biphasic defibrillators, 360 joules for older monophasic ones.
Pad placement is important for both.
Crucial. You want the current to flow through the heart muscle. Standard placement is one pad on the upper right chest below the clavicle, the other on the lower left ribs mid-axillary line. Avoid placing directly over implanted devices or medication patches. And yes, avoid placing directly over breast tissue if possible. Gently displace it.
AEDs make this accessible to lay people.
Automatic external defibrillators, yes. They analyze the rhythm and only advise a shock if VFib or pulseless VT is detected. They give clear voice prompts. Simple to use, save lives.
What about implanted devices? AICDs.
Automatic implantable cardioverter defibrillators. For patients at high risk of sudden cardiac death from VT or VFib, it's a small device implanted under the skin, usually in the chest, with leads going to the heart. It constantly monitors the rhythm.
And it shocks automatically.
If it detects VT or VFib above a certain programmed rate, yes. It can deliver a shock, often around 25-30 joules, sometimes multiple times if needed. It can also often function as a pacemaker.
What do patients need to know?
A lot. How it works, the rate cutoff, what a shock feels like a pick in the chest. What to do if shocked, call provider 911 depending on situation. Avoiding strong magnetic fields like MRIs, large motors, carrying their ID card.
And pacemakers, they prevent slow heart rates.
Exactly. They provide electrical stimulation when the heart's own rhythm is too slow or unreliable. It can be temporary or permanent.
How do they work? Synchronous versus asynchronous?
Synchronous or demand. Pacing is most common. The pacemaker senses the heart's own rhythm, intrinsic rhythm. If the intrinsic rate drops below the set rate, the pacemaker fires. If the heart beats faster than the set rate, the pacemaker remains inhibited. Asynchronous or fixed rate, pacing fires at a preset rate regardless of the heart's own activity, used less often now, sometimes temporarily. Overdrive pacing involves pacing faster than the intrinsic rhythm, sometimes used to suppress tachyarrhythmias.
How do you see pacing on an ECG?
You see a pacemaker spike a sharp vertical line right before the chamber being paced. An atrial spike precedes the P wave. A ventricular spike precedes the QRS complex. Capture means the chamber responded to the spike, depolarized.
Temporary pacemakers, different types.
Non-invasive transcutaneous pacing uses large electrode pads on the chest and back. Quick for emergencies, but can be uncomfortable. Invasive transvenous pacing involves threading a pacing wire through a vein into the right atrium or ventricle. Invasive epicardial pacing wires are placed directly on the hard surface during cardiac surgery and exit through the chest wall, usually removed after a few days.
Risk with invasive wires.
Microshock risk is a concern. Need to ensure equipment is grounded, insulate exposed wires, wear gloves when handling, keep dressings dry.
And permanent pacemakers.
The generator, battery and circuitry, is implanted in a subcutaneous pocket, usually below the clavicle. Leads are threaded transvenously into the heart chambers. Can be single chamber, pacing atrium or ventricle, or dual chamber, pacing both. Biventricular pacing, pacing both ventricles, is used in some heart failure patients. CRT, cardiac resynchronization therapy.
How long do they last? How are they checked?
Lithium batteries typically last around 10 years. They can be checked and reprogrammed non-invasively in the clinic, or sometimes remotely via telephone transmitter. Patients need education on pulse monitoring, activity restrictions initially, avoiding strong electromagnetic fields, carrying ID card, recognizing signs of malfunction.
Okay, let's move into coronary artery disease, CAD, the big one.
Fundamentally, CAD is the narrowing or blockage of the coronary arteries, usually due to atherosclerosis that build up of fatty plaque. This restricts blood flow and oxygen supply to the heart muscle.
And that leads to?
Angina, dysrhythmias, MI, heart failure, potentially death. It's the leading cause of death in many countries. Hypertension is both a cause and consequence.
Can the body compensate? Collateral circulation.
Sometimes. If the narrowing develops slowly over time, the heart can sometimes grow tiny new blood vessels that bypass the blockage collateral circulation, more common with chronic ischemia.
How does CAD present? What do you assess?
Symptoms can be varied. Chest pain or discomfort, angina is classic, but also palpitations, shortness of breath, dyspnea, fainting, syncope, cough, fatigue. Some people, especially women or diabetics, might have atypical symptoms.
Diagnosis.
ECG is key. Might show ST depression or T-wave inversion suggesting ischemia or signs of previous infarction like Q waves. Cardiac cath definitively shows the blockages. Blood lipid levels will likely be evaluated.
Interventions focus on risk reduction.
Absolutely. Lifestyle modification is huge. Stop smoking, manage BP and diabetes, healthy diet, low saturated fat, low sodium, high fiber, regular exercise, stress management. Medications play a big role too.
What kinds of meds?
Nitrates to dilate coronary arteries, calcium channel blockers, cholesterol-lowering drugs, statins are key,
Right.
beta blockers to reduce heart workload. Antiplatelets like aspirin are usually standard.
And surgical options we discussed earlier, PTCA, stents, CABG.
Yes, those are used when lifestyle and meds aren't enough for in acute situations.
Let's talk more about angina, the chest pain from CAD.
Angina pectoris is chest pain resulting from that imbalance between the heart muscle's oxygen supply and demand. The heart isn't getting enough oxygen for the work it's doing, usually due to narrowed coronary arteries.
Are there different types?
Yes, patterns are important. Stable angina, also called exertional angina, is predictable. Comes on with activity or stress, relieved by rest or nitroglycerin. Unstable angina is more dangerous, occurs unpredictably, maybe even at rest, lasts longer, is more severe, might not be relieved by nitro. It signals worsening disease, high risk for MI.
Any others?
Variant angina, or Prinzmetal's, is caused by coronary artery spasm, not necessarily plaque. Can occur at rest, often cyclical. ECG might show ST elevation during the spasm. Intractable angina is chronic, debilitating pain unresponsive to typical treatments. Pre-infarction angina is basically unstable angina that lasts over 15 minutes, often a warning sign days or weeks before an MI.
Assessment for angina.
Assess the pain carefully. PQ or RST provokes, quality, radiates, severity, time. Also check for associated symptoms. Dyspnea, pallor, sweating, diaphoresis, palpitations, dizziness, maybe nausea. BP might be high during an episode.
How is it diagnosed?
ECG during pain might show ST depression or T-wave inversion. Stress tests can provoke it. Importantly, cardiac markers like troponin will be normal in angina. That helps distinguish it from an MI. Cardiac cath shows the underlying blockages.
Immediate interventions for an angina attack.
Priority is pain relief and reducing myocardial oxygen demand. Have the person stop activity and rest. Administer oxygen. Check vital signs. Give nitroglycerin sublingually as prescribed, usually up to 3 doses, 5 minutes apart. Establish short V access. Get a 12-lead ECG quickly. Keep them in a semi-Fowler's position.
Long-term management overlaps with CAD.
Yes. Risk factor modification, medications, nitrates, beta blockers, calcium channel blockers, antiplatelets, statins, and potentially revascularization procedures like PTCA or ABG.
Okay, now the dreaded myocardial infarction, MI, or heart attack.
This is when that lack of oxygen supply goes on long enough to cause irreversible damage, necrosis, death of heart muscle tissue, usually caused by a complete blockage of a coronary artery, often a thrombus forming on ruptured plaque. The damage evolves over several hours.
Location matters, right? Depends which artery is blocked.
Absolutely. An LED blockage typically causes an anterior or septal MI. Circumflex blockage leads to posterior or lateral MI. Right coronary artery blockage often causes an inferior MI and may also affect the right ventricle and conduction system, SAAV nodes.
Risk factors are the same as for CAD.
Pretty much, yes. Atherosclerosis is the main underlying cause. So high cholesterol, smoking, hypertension, diabetes, obesity, inactivity, stress, all contribute.
How is MI diagnosed definitively?
Cardiac markers are key. Troponin levels will rise within hours and stay elevated for days. CKMB also rises and falls more quickly. Myoglobin rises very early, but isn't specific. WBC count often increases within a day or two.
And the ECG?
Critical. Can show different patterns. STEMA, ST segment elevation MI, indicates a full thickness injury and usually requires immediate reperfusion therapy. NSTEMA, non-ST segment elevation MI, indicates partial thickness injury. T-wave inversion and development of abnormal Q waves can also occur.
Tests after the acute stage.
Once stable, tests like stress testing, nuclear scans, or cardiac cath might be done to assess the extent of damage, check for residual ischemia, and evaluate overall heart function.
What are the classic signs and symptoms of MI?
Often severe persistent chest pain, described as crushing, pressure, tightness, burning, may radiate to jaw, neck, arms, back. Unlike angina, it's usually not relieved by rest or nitroglycerin. Also, nausea, vomiting, profuse sweating, diaphoresis, shortness of breath, extreme fatigue, anxiety, feeling of impending doom. Skin might be pale, cool, clammy.
Can MIs have complications?
Oh yes, many potential complications. Dysrhythmias are very common, including life-threatening ones like VTVF. Heart failure and pulmonary edema can develop if the pump function is significantly impaired. Cardiogenic shock is a severe form of pump failure. Other risks include thrombophlebitis, clots in veins, pericarditis, inflammation around the heart, rupture of part of the heart wall, rare but catastrophic, mitral valve problems or Dressler syndrome, a delayed form of pericarditis.
Acute interventions for MI. Time is muscle, right?
Absolutely. Immediate goals are pain relief, restoring blood flow, perfusion, reducing workload, preventing complications. Morphine is often used for pain, also reduces anxiety and preload. Oxygen is standard. Continuous cardiac monitoring. Frequent vital signs. Aspirin should be chewed immediately. Nitroglycerin may be given.
What about reperfusion?
For STEMI, the goal is rapid reperfusion, either with primary PCI angioplastistin within 90 minutes of arrival at the hospital, or thrombolytic clot-busting drugs within 30 minutes if PCI isn't available quickly, usually within 6 hours of symptom onset. Beta blockers are often started early. Monitor closely for bleeding if thrombolytics are used.
After the acute phase, what's the focus?
Healing and recovery. Bed rest initially, then gradual progression of activity, cardiac rehab. Monitor for and manage complications. Medications become long-term therapy. ACE inhibitors or ARBs, beta blockers, antiplatelets, aspirin, maybe clopidogrel, statins. Emotional support is crucial too.
Cardiac rehabilitation is important.
Very. It's a structured program of exercise, education, and counseling to help patients recover, regain strength, modify risk factors, and improve quality of life.
Let's move on to heart failure. What exactly is it?
Heart failure means the heart can't pump enough blood to meet the body's metabolic needs. It doesn't mean the heart stops, but it's failing as an effective pump. This leads to inadequate tissue perfusion and often volume overload, causing congestion in the lungs or periphery.
Can it be sudden or gradual?
Both. Acute heart failure develops suddenly, often after an MI or other acute event. Chronic heart failure develops gradually over time.
Different types, left versus right.
Yes. Most heart failure starts with the left ventricle, left-sided HF. The left ventricle weakens and can't pump blood out effectively, causing blood to back up into the lungs. This leads to pulmonary congestion, shortness of breath. Acute pulmonary edema is a severe form of left HF. Right-sided HF often results from left-sided HF or lung disease. The right ventricle weakens, blood backs up in the systemic circulation, causing peripheral edema, JVD, and enlarged liver.
Other ways to classify it.
Forward versus backward failure. Inadequate output versus backup congestion. Low output versus high output. Most HF is low output. High output occurs when the heart is working hard but can't meet unusually high demands, like in severe anemia or hyperthyroidism. Systolic versus diastolic failure. Problem ejecting blood versus problem relaxing filling.
The body tries to compensate, right?
It does. Mechanisms like increasing heart rate, retaining sodium and water via renin-angiotensin-aldosterone system, and the ventricular hypertrophy, muscle thickening, kick in to try and maintain cardiac output. But long-term, these compensatory mechanisms actually worsen the heart failure by increasing the heart's workload and causing further damage.
So signs and symptoms depend on which side is failing.
Largely, yes. Left-sided, dyspnea, especially on exertion or lying flat, orthopnea, cough, sometimes with frothy sputum, crackles in the lungs, fatigue, confusion. Right-sided, peripheral edema, legs, ankles, jugular vein distension, JVD, ascites, fluid in abdomen, enlarged liver and spleen, weight gain. Often patients have symptoms of both. Biventricular failure.
What about acute pulmonary edema? That sounds like an emergency.
It is. Severe dyspnea, orthopnea, tachypnea, tachycardia, anxiety, pallor, cyanosis, diaphoresis, wheezing, crackles throughout lungs, coughing up pink, frothy sputum, needs immediate intervention.
What are the priority actions for pulmonary edema?
Place the client in high Fowler's position, upright to ease breathing. Administer high-flow oxygen. Assess lung sounds and vital signs frequently. Administer medications as ordered, typically potent diuretics like furosemide IV to pull off fluid quickly, morphine 5E to reduce anxiety, preload and afterload, and possibly vasodilators or inotropes to support heart function. Monitor urine output closely.
Okay, moving to inflammatory heart conditions.
Pericarditis. Inflammation of the pericardial sac. Classic symptom is sharp precordial chest pain, often worse with breathing, coughing, or swallowing, and sometimes relieved by leaning forward. You might hear a pericardial friction, rub a scratchy sound. Major risk is progression to cardiac tamponade if fluid builds up.
Myocarditis.
Inflammation of the heart muscle itself, the myocardium, can be caused by viruses, bacteria, toxins. Symptoms can range from mild flu-like symptoms to severe heart failure, dysrhythmias, chest pain, may hear a gallop rhythm or murmur.
And endocarditis?
Inflammation or infection of the endocardium, the inner lining, usually affecting the heart valves. Higher risk in 5E drug users, people with prosthetic valves or certain valve defects. Symptoms include fever, fatigue, weight loss, new or changing heart murmur, signs of heart failure. Can also cause embolic complications, bits of infected material breaking off and traveling elsewhere. Look for petechiae, tiny red spots, splinter hemorrhages under nails, painful Osler's nodes on finger scoes, painless Janeway lesions on palm soles. Rest is important, but balance with activity to prevent clots. Antibiotics are key.
Cardiac tamponade, the dangerous fluid buildup.
Exactly. Pericardial effusion is fluid in the pericardial space. If it accumulates rapidly or becomes large, it can compress the heart that's tamponade. It restricts the heart's ability to fill during diastole, drastically reducing cardiac output.
Cue signs.
Beck's triad is classic. Low arterial blood pressure, distended neck veins, JVD, and distant muffled heart sounds. Pulsus paradoxus, a large drop in systolic BP during inhalation, is another sign. It's a medical emergency requiring pericardiocentesis draining the fluid.
Valvular heart disease. Valves not working right.
Either they don't open fully, stenosis, or they don't close tightly, insufficiency or regurgitation. Both disrupt efficient blood flow. Can affect any valve, but mitral and aortic are most common.
Examples.
Mitral stenosis restricts flow from left atrium to left ventricle. Mitral insufficiency lets blood leak back into the left atrium during ventricular contraction. Mitral valve prolapse is a bulging of the valve leaflets. Aortic stenosis obstructs flow out of the left ventricle. Aortic insufficiency lets blood leak back into the left ventricle after contraction. Symptoms depend on the valve and severity, often shortness of breath, fatigue, murmur.
How are valves fixed?
Sometimes repairs are possible. Balloon valvuloplasty uses a balloon to stretch open a stenotic valve. Mitral annuloplasty repairs the ring around the mitral valve. Commissurotomy valvotomy involves surgically separating fused valve leaflets.
Or replacement.
Valve replacement uses either mechanical prosthetic valve, very durable, but require lifelong anticoagulation due to clot risk, or bioprosthetic valves, made from animal tissue, porcine pig, bovine cow, or human cadaver tissue, homografts. Bioprosthetic valves don't usually require a long-term anticoagulation, but are less durable than mechanical ones. Pre- and post-op care is extensive.
Cardiomyopathy disease of the heart muscle itself.
Yes, it's a disorder affecting the structure and function of the heart muscle. Different types exist, like dilated enlarged weak chambers, hypertrophic, thickened muscle, and restrictive, stiff muscle. Leads to impaired pumping. Treatment is often palliative, managing symptoms of heart failure and preventing complications. Sometimes transplant is needed.
Okay, let's switch to vascular disorders. Venous thrombosis.
Blood clot in a vein. Can be superficial, thrombophlebitis, or deep DVT, deep vein thrombophlebitis, often associated with inflammation of the vein wall. Big risk is embolization.
The clot breaking loose.
What causes them?
Risk factors.
Virtose triad, venous stasis, slow blood flow like from immobility, surgery, long travel, hypercoagulability, conditions that make blood clot easier like certain cancers, genetic disorders, oral contraceptives, pregnancy, and injury to the vein wall, trauma, surgery, 5E catheters.
How does phlebitis present?
Usually a red, warm, tender area along a superficial vein. Warm, moist soaks can help dilate the vein and promote circulation. Careful with the temperature. Often calf or groin pain tenderness, maybe swelling, warmth, redness, sometimes subtle or no symptoms. Diagnosis usually via ultrasound. Key interventions: elevate the affected leg, apply warm compresses as ordered, administer anticoagulants like heparin and warfarin or newer agents, monitor for pulmonary embolism signs, sudden shortness of breath, chest pain, avoid massaging the leg, avoid pillows under the knees or using the knee gadge on the bed as it impedes venous return. Use anti-embolism stockings, TED hose, or sequential compression devices, SCDs.
Venous insufficiency, chronic problem.
Results from long-term venous hypertension, often due to previous DVTs damaging valves or weak vein walls. Valves become incompetent, blood pools in the legs, leads to chronic edema, brownish skin discoloration, stenosis, and venous stasis ulcers, especially around the ankles. Management includes leg elevation, compression stockings consistently, meticulous skin care, and wound care for ulcers.
Varicose veins.
Dilated, tortuous, protruding superficial veins, usually in the legs, caused by incompetent valves allowing blood to pool. Can be cosmetic or cause aching, heaviness, fatigue. Trendelenburg's test can help assess valve competence. Interventions include anti-embolism stockings, elevating legs, avoiding prolonged standing, sitting, exercise. Sometimes sclerotherapy or surgical removal is done.
Now, peripheral arterial disease, PAD, problem with arteries supplying limbs.
Yes. Chronic occlusion, usually from atherosclerosis, deprives the lower extremities of oxygenated blood. Tissue damage occurs below the blockage level.
Classic symptom.
Intermittent claudication, cramping pain, or aching in the calf, thigh, or buttock muscles during exercise, relieved by rest. Caused by muscle ischemia during activity. Other signs: cool, pale skin, diminished or absent pulses, hair loss on legs, feet, thickened nails, dependent rubor, redness when leg is down, potential for painful arterial ulcers, often on toes, feet, or gangrene. Management: risk factor modification, smoking cessation is crucial. Exercise program: walking to the point of pain, resting, then continuing. Medications: antiplatelets, silestazole for claudication, meticulous foot care, and possibly revascularization procedures.
Raynaud's disease. That's different, right? Spasms.
Yes, vasospasm of small arteries, usually in fingers and toes, triggered by cold or stress. Causes distinct color changes: white, pallor, then blue, cyanosis, then red, rubor, as blood flow returns. Can be painful. Management involves avoiding triggers, keeping hands, feet warm, stress management, sometimes calcium channel blockers.
Berger's disease.
Also called thromboangitis obliterans, an inflammatory disease causing thrombosis and occlusion of small and medium arteries and veins, mainly in the hands and feet, strongly linked to tobacco use. Can lead to claudication, pain at rest, ulcers, gangrene. Absolute smoking cessation is essential.
Aortic aneurysms bulge in the big artery.
Exactly. An abnormal dilation or outpouching in the wall of the aorta caused by weakness can be fusiform, uniform dilation around circumference, or saccular pouch-like. A dissecting aneurysm involves a tear in the inner layer, allowing blood between layers. A false aneurysm is a contained rupture, most common in the abdomen, AAA, below the renal arteries, but can occur in the thoracic aorta too.
Big danger is rupture.
Yes, rupture is catastrophic, high mortality. Signs of impending rupture or dissection can include sudden, severe abdominal or back pain, often described as tearing or ripping for dissection, pain radiating to flank groin, shortness of breath, thoracic, pulsatile abdominal mass, AAA, signs of shock, hypotension, tachycardia.
Managed.
Small, asymptomatic aneurysms might be monitored with regular ultrasounds. Control blood pressure strictly. Surgical repair is indicated for larger aneurysms, for example, 5.5 centimeters for AAA, rapidly expanding ones, or symptomatic ones. Repair can be open surgery, replacing segment with a graft, or endovascular aneurysm repair, EVR, inserting a spent graft via catheters. Post-op monitoring of peripheral circulation, renal function, and graft patency is crucial.
Briefly, embolectomy. Removing a clot.
Surgical removal of an embolus, a traveling clot or debris, that is lodged in an artery, blocking blood flow, often an emergency to save a limb or organ.
And vena cava filters. Ligation.
For patients with DVT who can't take anticoagulants or have recurrent PEs despite anticoagulation, an IVC filter is placed in the inferior vena cava to trap clots traveling from the legs, preventing PEs. IVC ligation, tying off the vein, is rarely done now.
Okay, nearly there. Hypertension, high blood pressure.
Defined generally as systolic BP persistently, 140 millimeters Gr or higher, or diastolic BP 90 millimeters Gr or higher, although guidelines now often use lower thresholds like 30/80 for stage 1. Prehypertension is 120/129 systolic and 80 diastolic, called the silent killer because it's often asymptomatic until organ damage occurs. Major risk factor for stroke, MI, heart failure, kidney disease.
Treatment goals.
Reduce BP to target levels, often less than 80, depends on individual factors, and prevent or minimize target organ damage, heart, brain, kidneys, eyes. Lifestyle modifications: diet, DHH diet, low sodium, weight loss, exercise, limit alcohol, smoking cessation are foundational. Medications are often needed: diuretics, beta blockers, ACE inhibitors, ARBs, calcium channel blockers, etc., often used in combination.
Hypertensive crisis. That sounds bad.
It is. A severe abrupt elevation in BP, typically 100 and 120 millimeters Hg, can be urgent, no immediate organ damage, or emergent, evidence of acute organ damage, brain, heart, kidneys. Requires immediate BP reduction, but not too rapidly, in a controlled setting, usually with IV medications to prevent further damage. Maintaining airway is priority if consciousness is affected.
Wow, that was comprehensive. We've covered an enormous amount of ground on cardiovascular disorders and nursing care, right from basic AMP through complex diseases and interventions.
Absolutely. It really underscores how interconnected everything is within this system and how crucial those concepts of health promotion and perfusion are for patient outcomes.
Okay, let's revisit that critical thinking challenge. Hospitalized patient, known AAA, sudden severe back pain and shortness of breath. What's the nurse's first action?
The immediate priority is to notify the registered nurse and the healthcare provider right away. Don't delay.
Why so urgent?
Because severe back pain could mean the aneurysm is rapidly expanding or even starting to rupture. Shortness of breath might indicate pressure within the chest or even dissection extending upwards. Both are signs of a potential catastrophe requiring immediate medical and likely surgical intervention.
Crucial point. Okay, as we wrap up this deep dive, here's a final thought to ponder. Considering everything we've discussed about the cardiovascular system, how significantly might lifestyle choices made early in life impact long-term heart health? And maybe, what role can each of us play in promoting proactive heart health awareness in our own communities?
That's a powerful takeaway. Thinking about prevention and long-term well-being, not just treating disease after it happens, it really highlights the importance of education and advocacy.
Couldn't agree more. And with that, we have successfully navigated the entire cardiovascular chapter from the Saunders NCLEX-PN Examination review. Thank you so much for joining us on the deep dive.
Thanks for listening.